Thank you. I had to go into the audio settings after it signed out. So,
Grand.
Okay, do we have a quorum, Clerk?
Yes, we have members there, Colin, and the officials are ready, so work away.
Okay, well, good morning, members, and I would like to now declare the meeting open to the public online. I'd like to welcome all of our members participating by video conferencing and to thank members for your attendance at this urgent meeting of the committee. Can I remind members about the protocols regarding the use of electronic devices? So members, we have received one apology from Mr. Jerry Carroll. Are members aware of any other apologies? No. Okay, thank you. Members, we're moving on then to our substantive briefing, which is a departmental briefing. So we have officials here today to brief us on the current increase in the COVID numbers and the rise in admissions to hospital and to ICU. We requested to be briefed on three particular areas: the increasing number of cases, including information on modelling projections and forecasting, staffing problems as highlighted by the trusts, and on vaccinations. So I would now like to welcome the following officials to our meeting this morning. Mr. Ian Young, Chief Scientific Officer. Can you hear me there, Ian? Okay, and so I'm not hearing you at this point in time.
I can.
Okay.
Yes.
I can hear you there, Ian. And we are also joined by Patricia Donnelly, who's head of the vaccination programme. Good morning, Patricia. Can you hear me?
I can hear you very well. Good morning.
Thank you, Patricia, and good morning. And Mr. Paul Kavanagh, who's the Interim Director of Planning and Commissioning within the HSCB, the Health and Social Care Board. Can you hear us okay, Paul?
Yes, good morning, Colin.
Good morning. So good morning, everyone, and I want to welcome you here to the meeting this morning. And just to say that if everyone in the meeting, when you're not speaking, can keep yourself on mute, and if everyone can use or has access to a headset, that is generally helpful with the sound quality. So I will go back to the panel then and invite the officials to brief the committee, and then we'll go into a round of questions and answers, please. So I'll go back to yourself, Professor Young. Can you outline for us how you want to manage the briefing end of things before we go into the question and answers?
So I would be happy to summarise the current position in relation to case numbers, hospital admissions, etc., and then comment on where we are in relation to modelling in terms of what might come next.
Okay, thank you. Well, so do you want to go ahead and do that, and then I'll go to Patricia, and then we'll take the three brief opening remarks, and then we'll go into questions following that. So if you want to go ahead, Professor Young.
So as members will be aware, there has been a progressive increase in case numbers throughout the month of July. And the number of cases is now at around 60% of the number in the previous wave. It has been rising with a doubling time of approximately 7 to 8 days. But over the course of the last week, case numbers appear to have plateaued and have levelled out. There are two potential reasons for that. Number one, it may be a consequence of the most unusual weather of the last 2 weeks. You are aware that in general the virus spreads less well when individuals are outdoors, and also spread is reduced in the presence of good ventilation. So we believe that there's been a high level of outdoor interaction in the last 2 weeks, and in addition that almost everybody has had their windows open, encouraging ventilation and airflow. And there may have been a significant beneficial effect of those two things in terms of reducing the rise in case numbers. If that analysis is correct, then we would expect the upward trajectory of case numbers to resume, and that will become apparent next week. The second possibility is that there is a key subgroup of the population who are mainly responsible for driving the epidemic. They would be younger people with large numbers of social contacts. And if that subgroup of the population achieves a high level of immunity as a result of exposure to the virus, then the impetus that they provide to transmission will decline, and we may see an ongoing decline in case numbers. Now, we're not really going to be sure about which of those two possibilities is correct until I think next week, depending on whether case numbers decline a little more or whether they continue to rise. In terms of modelling of case numbers, we have three scenarios, a pessimistic, a central, and an optimistic scenario. And we're following very closely the central scenario in terms of case numbers. If it had continued unabated, we anticipated that we would peak at somewhere around 3,500 to 4,000 cases per day if everyone was coming forward for testing. Always an unlikely scenario. But in the last few days, we have dipped below central. So we're doing slightly better than the central case scenario for the reasons or potential reasons that I have described. So secondly, moving on to hospital admissions and pressures. As members will be aware, there is a lag period between an increase in case numbers and an increase in hospital admissions. And that lag period follows after around 8 days in terms of hospital bed occupancy. So we have been seeing the anticipated rise in case numbers in terms of admissions, then in hospital bed occupancy. And at current modelling, we are tracking somewhat between the central scenario and the pessimistic scenario in terms of hospital pressures. Under the central scenario for hospital pressures, we would peak at somewhere around 400 inpatients towards the end of August, numbers gradually rising until then. Numbers continue to rise at present, but if indeed case numbers stabilise and begin to fall, then I expect that hospital inpatient numbers will stabilise probably towards the end of next week. If case numbers begin to rise again as a result of the weather deteriorating, then there would be a further increase in hospital admissions and pressures after that. At present, the number of COVID patients in hospitals remains around 1/3 of that was observed in the previous wave. So the proportion of individuals who are identified as cases who become admitted to hospital is falling and has fallen as a result of the beneficial effects of vaccination, which Patricia will, I think, reference later. So during the last wave in February, we were admitting 5 to 6% of cases to hospital, and at present it's somewhere between 3 and 4% of cases which are being admitted to hospital. In terms of critical care, the pressures on critical care have been towards the upper end of what we might have anticipated, although I have to stress that there's still only around 1/3 of the numbers that there were during the previous wave. We believe that's likely to be due to the fact that younger patients are now being admitted to hospital as cases, and that the threshold for admission to critical care may have changed somewhat. A similar effect has been observed in Scotland, though it's difficult to get accurate information on that. And it's something that we continue to keep under review. But in essence, critical care numbers will rise until admission numbers and inpatient numbers stabilise, and then they will begin to fall again after a further lag. Finally, in terms of modelling, the outcome of modelling is critically influenced by the extent to which we get vaccine uptake. The initial modelling we did for this summer wave assumed 85% first dose vaccine uptake by adults by the end of July and 90% by the end of August. We had to revise the modelling earlier this month to account for the fact that we were unlikely to reach 85% first dose vaccine uptake. I think we're currently sitting at a little over 83%. That reflects huge efforts, as all members will be aware, consistent messaging and walk-in vaccine centres, mobile vaccine units being taken to areas where younger people who are less likely to be vaccinated congregate. And we'll continue to push that. I have to note that we lag behind England, Scotland and Wales in terms of first dose vaccination by around 5 to 6% minimum, and in some cases by more than that. In terms of second doses of vaccination, we're very similar to England and Scotland, but we lag behind Wales by about 10%. So there has been a concern that the willingness of the Northern Ireland population to come forward for vaccination, for whatever reason, seems less than that in other parts of the UK. And that will lead to a larger susceptible population in Northern Ireland, and therefore the potential for a more severe wave on this occasion. Every small percentage increase in vaccination that we can achieve will make a real difference in terms of how quickly the current wave will resolve and the potential for future waves. So that's my summary of the current position.
Okay, thank you. And Patricia, then, in terms of the vaccination?
Good morning, Chair. If you're content, I was going to show a few slides to summarise some things that are familiar to committee, but maybe just give an update. I'm hoping that I should be able to share a screen. If I apologies, I've already I've sent the presentation to the committee. I can't seem to get it up. Keith, I think that went earlier this morning.
I'll check and see from here, Patricia, and see if we can get it up.
Okay, thank you. I'll start anyway. On that presentation, I will have reminded members of the plan for the programme. And although we're at exactly the same stage of the plan, we are, as Ian has mentioned, it has very much, the uptake has slowed down for this period. We were the first in the UK to open to the under 30s, and that's been open for 2 months. However, their uptake has been incredibly slow. And in fact, the dashboard that I was going to show will indicate that we have thank you. If we could go to the slide 4, please. Fourth one down.
Sorry, Patricia, there is a wee bit of a lag in the system.
That's okay.
For the.
But it has shown that we have, again, 2.2 million doses administered. But as Ian says, 83% of the population, adult population, and 71% are fully vaccinated. But our issues will be, I think I'll move on to slide 5 when you get a chance, Keith, will show the update. Thank you. That's the uptake rates. And this is where I think the story lies. If we go through, you'll see these are based, that cohort, you'll notice along here where it says cohort size, will tell you the size of the population we were targeting in this. Now, this is based on the 2019 mid-year population estimates. We're going to move very shortly, you'll see next week, to the 2020 mid-year estimates, and it will change that slightly. It will show a slightly older, more in the older population and fewer in the younger population. So it will adjust these figures slightly. It will take us down to less than 100% in the over 70s and 80s, but not by more than 1% or 2%, and it will take us up 1% or 2% in the youngest age groups. But we are comparable and indeed ahead of other parts of the UK and Ireland in terms of our uptake until we get to the under 50s. And then you'll see from 40 to 49, only 83% of the population, and then it drops down further to 70% for the 30 to 39s. They're still coming forward, but very slowly, and we've not yet reached 60%. Keith, could you go to the next one, please? Again, members will be aware that we had 7 vaccination centres. In the last month, the bookings to these centres have been very low, so we started to open it to walk-ins. We would do anything to try and get people to come forward, but even those are very low. The last couple of days has seen a pickup as we're nearing the end of first dose completions there, and we'll continue there with second appointments to mid-July. But the real energies in the last 4 to 6 weeks have been in pop-up and mobile teams. We've had over 35 already out there and many, many more planned. We are informed by the information about where the uptake rates are. We're informed by where we believe we're going to find young people. So we're in high streets, we're in estates. We've had a series of initiatives with the food industry to increase uptake. We work with sports bodies, event companies, further education colleges, universities. We have a big 2-week period at the beginning of term planned for those that are returning to further education. We've had community pharmacies who were delivering AZ, which are continuing to do. And you will know, Chair, that AZ was not recommended for the under 40s. So we've developed an initiative with 16 pharmacies to handle the Moderna vaccine, a more complex vaccine as a messenger RNA. But this week sees 16 pharmacies scattered through Northern Ireland. This will be phased up in August to 80, and we hope even more in the autumn. And we call this the Evergreen programme. So anyone who's missed the main vaccination programme who still wants to be vaccinated, you go to community pharmacy, they will continue to vaccinate. GPs, 321 of them are completing the second doses. We go to the next slide, please. Okay, and we've recently had an interim advice for the under 18-year-olds. So just when we're nearing the end of this part of the programme, they've recommended no blanket vaccination for the under 18s, and we'll use Pfizer vaccine with this group. So you'll see in the left column what the advice is. This is interim advice. It's not yet fully resolved, but on that basis, we're planning. And anyone who will be 18 by the 31st of October already can walk in or book to a vaccination centre. Anyone 16 and 17 at a greater risk of serious COVID, effects of COVID, can also go to book in or walk in a vaccination centre. And anyone over 12 years of age in a household of someone severely immunosuppressed, they will get a letter from the GP from Trust. We did this some months ago with the 16 to 17-year-olds, and we welcome the advice for 12 to 15-year-olds. So although the vaccination centres will close to the general public, these individuals and these children and their parents can still attend with their letter, and they will be vaccinated. And we'll be communicating that to them this week. Many will already have received those letters, and indeed those vaccinations have started. And then a really important group of 12 to 15-year-olds with specific health conditions. JCVI are very clear about who falls within this. You'll see the list. And what has happened is our Child Health Partnership Group, that's the paediatricians and those in hospitals and community, are working with the Trust and the Public Health Agency to identify them. They should be receiving letters very shortly, and we'll invite them to invitation to vaccination. And they'll either come to special sessions in the vaccination centres, or they will go to designated special schools where we'll have set those up. That will be the week commencing the 9th of August. So that's coming up very shortly. The next slide, please. Okay, so this is really, it's been of enormous concern to us that right from the start we were aware that our very fast uptake rate just slowed dramatically. It went off a cliff in June when we moved to this age group. So we worked with the behavioural insight team, and they said to us, yes, some might have safety concerns, but the majority, it was all about convenience. They didn't really believe they were going to be greatly affected. They didn't like to go by themselves. They preferred to go in groups. What other people said was really important. So those who would influence young people, making sure they had the right messages, and they would use social media rather than traditional media. So we moved in the vaccination centres from the booking system to walk-ins. We'd had a no photography rule to protect the privacy of individuals, and we realised that if we didn't allow the opportunities for selfies, it may not actually even be seen as an important event. So we created those areas within the centres, and we tried some novel means. You will have heard in SSA Arena, they had an ice cream van for a period of time, mainly to draw attention to the fact that it was there. But it's been the mobile clinics that have really started to have an impact. Very slow. These are hard yards. These are very challenging. But in high street locations all across towns, villages in Northern Ireland, also we're informed by the vaccine management system on the areas of low uptake. So we've gone to estates, we've gone to locations, and people have come out. It's been very heartening to see it. We've provided at it sports matches, both football matches, GAA matches, and we will be providing vaccination opportunities at some of the entertainment events that are coming up. And in the term opening, we'll go to further education colleges and universities. And you may have seen some media last night, again, at antenatal clinics. We know that pregnant women are particularly vulnerable to this virus. And the PHA have led a mass media campaign through digital channels and through social media. And if you go to the next one, you'll just see a little bit of a snapshot. These are some of their targeted campaigns about different areas. So I think that's just a sample of it. And then the very last slide, please, which is really saying, well, there's, as of this morning, it's 71% fully vaccinated, 83% first doses. At the current run rate, we will hit 85% during August. But we need 31,000 for 85%. 31,000 2 months ago meant nothing to us. We were vaccinating 90,000 people a week, and that was remarkable. We're lucky to do 1,000, 2,000 a day. So that is much more of a push, and you'll see the numbers that we need to get those higher numbers. But we are aware, Ian and his colleagues remind us that every 5% more people we can get vaccinated will significantly reduce hospitalizations. We can take the screen down. Thank you. Very happy to answer any questions, Chair.
Okay, thank you. And I'll go then across to Paul to see, Paul, do you have some opening remarks that you wish to make?
Yes, thank you, Colm, and good morning, committee members. Colm, we've over since the last wave passed us in March time, we've seen really unprecedented pressures within our hospitals, and committee members will be well aware of the media attention on our emergency departments, on ambulances queuing, on pressures within our EDs and within our hospitals. And a lot of that has been relating to unscheduled care. And we really have been working hard to see if we can, progress that, change the position in relation to it. But the numbers keep coming. And we've reflected on that this is currently sort of in the middle of summer, probably one of the worst winters we've ever seen. And it is, I suppose, in that context, Colm, that I want to just remind members of the pressures that were already within our hospitals before this fourth wave approached us. At the same time, we've stood up a lot of our elective surgery, which we had stood down, as you know, through the second and third waves largely. In recent weeks, we've been performing some 3,700 surgeries per week. So, we've been able to stand up quite a bit, but we also know we've got a lot more than that to be doing to catch up with the considerable backlogs that, again, committee members will be fully aware of. But I suppose as this wave has approached us probably about 2 weeks in advance of what we expected, Colm, I think we've had to very quickly move into our contingency mode. And a few things then I think are worth noting for members. And I suppose it's also worth noting that GPs are under considerable pressure as well. We continue to have GP-led COVID centres, as you know, but in many ways the pressures across our system continue. So in relation then to COVID specifically, you'll be aware that one of the indicators that we look for is actually the number of respiratory patients in our hospitals. So we have some probably 3,000 beds available in our hospital at any time, and around 11% of those currently have COVID patients in them, which is very much in line with Ian's figures. So it gives you a sense just of the kind of numbers that we're talking about. And about 60 of those patients we call enhanced respiratory care patients. So they're patients who probably have underlying respiratory conditions, some who will just be badly affected by COVID as well. And we really have those on additional support due to those respiratory conditions. And we want to ensure within our hospitals that our oxygen supplies are good, which they are. We've just checked over the last day or so in terms of our community oxygen supplies. That's also good. So at the moment, we're well able to cope with any oxygen demand that we might have. We're also very conscious that there's a pediatric virus going around at the moment called RSV, which may actually be a impact on more infants. It usually impacts on sort of not the 1-year-olds, but this year it might also affect some 1 to 2-year-olds as well. So our pediatric services are keeping an eye on that as well at the moment. But it's not COVID related, but it's coming at the same time as this wave as well, and will continue into the winter period. So our respiratory patients we're very conscious of at this stage, and those respiratory patients as well, some of them, I must emphasise, not all of them, but some of them may require critical care, intensive care. So that's why we keep an eye on the respiratory patients. And over the last few days, we've worked hard to ensure that we have all of our critical care beds open. We have 88 beds across Northern Ireland, and we currently have 86 of them open. And that's a much better position than it was 5 days ago. And in having all of those beds open, we then have more beds available, because there came a point when we felt that we just didn't have enough headroom in critical care. Now we have some 13 beds available, and that gives us, I think, a considerable amount of headroom. Interesting as well, Colin, because we asked the question about vaccination in relation to those 73 patients that are currently within our ICUs, and some 2/3 of them are unvaccinated. So that gives you a sense of the issues that we're facing in relation to vaccination and the importance of vaccination as well. We also know that some of those patients are a lot younger than they would have been in previous waves. So on that basis, it's a very different demographic that we're looking at as well. And of those 73 patients, it's worth noting as well. Sorry, I need to explain that a bit better. Of the 73 patients in critical care, 34 are COVID patients, and 2/3 of those 34 then are unvaccinated. So apologies, Colin, if I've confused in any way. So our critical care pressures are considerable. Added to our unscheduled care pressures, on that basis, trusts now have had to look just at how they can, I suppose, ensure that we actually deliver all of those critical care beds, that additional respiratory care that we need to provide. And unfortunately, trusts now have had to say that they've got to step down some elective care operations, as committee will be aware. So we are performing on average around 3,700 surgeries per week. And I think this week we've had to step down some 120 of those surgeries due to the pressures, particularly in Belfast, and largely orthopaedic patients. So it's awful for those patients, of course, but given some of the staff pressures that we face, we felt we had no choice. And important also then to emphasise that this is also about having enough staff to deliver the services that we need to deliver. Some 1,800 staff are currently off due to COVID. Some of them are infected. But the vast majority of them are actually isolating due to contact with others who have tested positive. So it's a large number of staff that are currently unavailable to us. And obviously we're looking at where the opportunities are for those double vaccinated staff, the majority of whom are double vaccinated, of course, or we can actually see how we can maintain them in work despite coming into contact with someone who has been infected. The other big issue for us as well at the moment is ensuring that our discharge from hospitals is going very much like clockwork, and that is very challenging. Just yesterday, Colin, we had some 229 patients awaiting beds within our hospitals. They needed to be admitted. And we had some 308 patients who were awaiting discharge. So they were medically fit, they were ready to go. So on that basis, we actually had more people needing to be discharged than actually the number of people that needed beds. So if we can move those discharges on, and on that basis, the Trust then have taken the decision to work with families to see if we can actually move those discharges on much faster. It's worth noting that of all of our care home beds within Northern Ireland, about 12% of those beds are actually available to us. But there are issues in terms of using those beds. Some of it is about the kind of the isolation that's required for a new care home patient to come into a care home. And some of that obviously is the additional staff requirement that relates to it. But some of it also is sort of patient and family choice in relation to which care home they would like to go to. We are having to actually say to patients and families, look, we need you to move to this care home sooner rather than later. And we'll obviously look then at the sort of your needs thereafter. We also are challenged in terms of our community, in terms of our domiciliary care services and packages available. So it is in many ways, Colm, a very complex picture. There are many pieces that have to fit together, and this fourth wave of COVID has just made that complexity even more complex.
Thank you. Okay, so I'll go back first of all then to yourself, Ian, in relation, and first of all, before just if I can clear up, so the committee obviously has reconvened in light of the very serious situation that we're hearing being reported. One of the key impacts of that is first and foremost on patients who are now experiencing surgeries being cancelled, very significant surgeries, people in pain, people with extreme worry about what's going on with their case or with their cancer, and we know there are cancer operations cancelled. The committee had asked that the Chief Medical Officer, the Minister, the recognising what Paul has just said, the complexity of the issues that we're dealing with, we had asked for a range of people. We had actually been indicated that we would be able to talk to the Chief Nursing Officer, and we were keen to do that, given that staff are under so much pressure at the current time, and we wanted to explore that. But can you just clear that up as to we thought we were getting the Chief Nursing Officer and that you actually weren't available, and now we find that you are available, but the Chief Nursing Officer not. So I'm just wondering how that has come about.
Chair, I obviously can't comment on the availability of other officials in the department. Officials are under huge pressure at the moment, as you rightly indicate, as a consequence of the course of the epidemic. I was able to cancel other commitments to make myself available to the committee.
Okay, and I do think the committee clearly has a key interest and does need to speak to those people. So I hope that doesn't impact negatively on our ability to drill into the current situation. So I will now go on to that situation, and I have already referenced there the pressure that has been placed on staff. I also have been speaking to people who have directly, as of yesterday, have had operations cancelled. One woman that I was speaking with was to go in for a surgery on cancer. She has been told by 3 consultants she's red flag, had been isolating, had been tested. Her children had to move out of the home, and her operation was cancelled yesterday, and she has no idea when that operation is happening. She can't bring the children back into the home because the isolation needs to continue. And people like that in that position are wondering, given that we are now in the fourth stage and the fourth surge of COVID-19, and the committee has always said that we will be supportive and we will provide scrutiny and advice, but that we would be keen to see learning developed and learning implemented. So we know this has happened in the previous surges. We know the hospitals come under pressure. We know there is finite resource within the hospitals. So given all that, what has went wrong on this occasion that sees us now back in the situation that we have been in previous surges, and how could that have been avoided?
So I'll comment first of all briefly, and then I think Paul will pick up on some of those issues. Obviously, the waves of the epidemic impose considerable additional pressures in terms of COVID admissions. And at the moment, the current wave, I hope, will lead to less hospital pressures as a direct result of COVID than previous waves have done. That's a consequence of the success of the vaccination programme and all of the efforts which have gone into ensuring that that's the case. I think we're all acutely aware of the pressures on our colleagues in primary care and in the hospital system as a result of this wave occurring in the summer, when some people will have holidays booked, and exhausted staff, I think, need to take holidays and breaks to ensure their resilience. Secondly, as a result of the number of people who may have needed to self-isolate, because we're having this wave in the context of both larger case numbers and cases having larger number of contacts as a consequence of the relaxations which the executive have approved and society moving slowly back to normal. Clearly, the smaller the epidemic in terms of case numbers, then the less those pressures will be. And we need to remember that the focus has to be on pushing vaccination, encouraging adherence to positive behaviours, and trying to minimise the size of the current wave. And with that context, I think Paul can comment on the issues around that the trusts are facing specifically.
Yeah, thanks, Ian. I think, Colin, there are 3 or 4 issues that have led us to this point. One is this unrelenting, unscheduled care pressure that we've had since April. So here we are in July, the end of July, and we've actually been experiencing this for some months now. A large number of people coming to our emergency departments, a large number of people requiring appropriately to be admitted to hospital, and then challenges in terms of discharge to clear our beds and so on for others who are coming each day. So it has been very challenging for us on that basis, and our hospitals then have been under severe pressure throughout that time. But also throughout that time, as we got our elective care and our elective surgery up and running again, we've protected that. And we've managed to actually keep our head above water in terms of the levels of surgeries that we've been able to provide. Some 3,700, as I said before, provided sort of at this stage. So it has been a challenging period, but we've kept our sort of what we call green sites and green pathways, so the non-COVID areas that allow us to maintain our elective surgery as much as we possibly can. But unfortunately, as the time has gone on, staff availability has become more challenging. This wave has affected staff, both in terms of staff who have become infected and staff who have had to isolate due to coming into contact with someone who has tested positive. So on that basis, that with actually the annual leave which staff need, our staff have been really under huge pressure for 18 months almost at this stage. We need our staff to take our leave, to recuperate, and to actually to be ready for what's ahead in terms of the real winter that's ahead as well. So staff availability is a particular problem for us right now, which it wasn't quite a month ago. So on that basis, Colin, I think that has been a key issue for us. And on top of that, then we've had to ensure that all of our critical care beds, our respiratory care beds and so on, are available to us, so that as further patients come forward, that we are ready for that. And that does have some impact then on theatre services, because we have to draw on theatre nurses, we have to sort of use some of the kind of sort of theatre capacity in order to support the likes of our critical care and respiratory care. So, and on that basis, this week, and it hasn't happened up until this point, that this week we've lost, as I said before, some 120 surgeries, so including some which are cancer surgeries. I'm actually the cancer lead in the board, so I'm fully aware of that, and I'm very disappointed, and I really am sorry that we haven't been able to maintain those surgeries. We also know that we need to do more surgeries than the 3,700 we've been doing in recent weeks. We're doing all that we can to actually ramp up. This further surge just has limited us in terms of further ramping up. But it is very, very challenging. We've some very hard-working staff doing the best that they possibly can. But unfortunately, this week we reached the tipping point, and we've tried to minimise the amount of surgeries that have had to be cancelled. But there's a clear commitment to get those surgeries rescheduled as soon as possible.
Thank you. And going back then to yourself, Ian, in relation to what Paul has touched upon there, the complexity of the system, the fact that staff breaks need to be factored in, and that's an important part of it. The issue around the capacity within the hospitals, capacity of staff, capacity of theatre space, capacity within critical care, supplies of oxygen, all that's interrelated. So I presume that is all factored into the modelling which you provide to the executive, and that modelling takes account of the fact that we are heading into a period of time when we have certain amount of vacancies within the staff cohort, we're expecting a certain amount of annual leave and the additional pressures. So does the modelling take account of that? And if it takes account of that, then was it predictable that the hospitals, knowing they were already on 100%, that if COVID cases rises, the hospitals would inevitably be overwhelmed and surgeries would have to be cancelled to cope?
So the modelling which we provide, firstly, modelling is not a prediction, as I continually said, and the outcomes of modelling reflect what will occur in particular scenarios. Which scenario was followed depends on decisions which are made by ministers in relation to relaxations. It's influenced by vaccination uptake, and it's influenced by then behaviours of individuals in terms of their levels of adherence to the restrictions which are meant to be in place. The modelling also is only addressed at numbers of COVID cases and number of COVID cases which are likely to lead to admissions and hence critical care. So the modelling which we conduct for the executive does not take into account those broader factors. The COVID modelling then is provided to the board and colleagues in the PHA.
Sorry, Ian, just let me put you back. So you're saying that modelling is not provided to the executive. So how can the executive then, if that's relevant, how can the executive factor that into their considerations?
So the modelling which we provide to the executive is modelling of the COVID epidemic. It's not modelling of the broader picture. The modelling which we provide to the executive around COVID goes to the board, and the board then have commissioned additional modelling which looks at the likely impacts on individual trusts. That modelling goes to the individual trusts, and my understanding is that they aim to plan their services based on their understanding both of admissions which may come from COVID and also other pressures, including staffing pressures and other healthcare problems.
Well, sorry. Just, I'm still struggling with the concept around the executive not getting the broader picture. I don't understand how the executive can make informed decisions if they don't know the broader picture and what the outside, not only what the COVID numbers are, but what the impact will be in the reality of the situation of the health system that we have in place to cope. So I don't understand.
So to be clear, the executive do receive an update in terms of the broader picture around the pressures which are faced by the healthcare system, both primary and secondary care. But specifically the modelling which is carried out is not modelling which deals with the totality of pressures. And that is the case with the modelling that's provided throughout the UK to different UK governments, and modelling which is carried out in the Republic of Ireland. Modelling
is that a flawed approach, given that we are dealing with the current situation where the impact is flowing into the everyday situation? So is that a flawed approach?
It's not possible to do that modelling, unfortunately. The system in which we operate is too complex, the number of variables is too great. It's not a flawed approach, it's just not possible to model effectively the totality of everything in the context of an epidemic of this kind. Nobody does that.
Well, listen, we have asked in previous occasions, but can you forward that modelling that you're providing to the executive to this committee so we can apply our scrutiny to that? Can that modelling be provided to the committee?
The Chair will, I think you're probably aware that we published some modelling earlier in July.
I've seen that modelling, Ian. I've seen that in response to being told that previously at a previous committee meeting. I have seen that, but surely that's not the entirety of the modelling. That 5-page of modelling is not the entirety of what the executive are working from.
No, we provide modelling on a weekly basis to the executive, which includes current modelling and an update on how we're performing against that. You'll appreciate that any decision about publishing that modelling and making it available is one for the executive, and it's not a commitment which, as an official, that I would be able to give.
And in terms of the trust modelling and the modelling to the board, is there further information you can provide the committee in relation to that?
I can't, because I don't see that modelling and I'm not involved in it. Paul may be able to comment on that.
Modelling comes to me, Colm, and it goes then to Trust, and Trust then use that as the basis of their sort of, I suppose, thinking through what staff they require to provide beds and so on. I'm happy to take that back and with a view to sharing that with the committee. But I mean, it is. I would have to just emphasise it is pretty high level, and it's how the Trust then interpret that.
Okay, thank you, and I want to move on to other members as well. So I will move on that. I look forward to getting that. You know, what's clear is here, and this is what people out there in the public are saying, you cannot continue to do the same thing and expect a different outcome every time. So we have seen in every previous surge of this where the numbers increase, they rise exponentially, they get out of control, and they put the pressure onto the healthcare system. And that's right across the system: GPs, emergency departments, paramedics, everyone comes under pressure. So what we as a committee are looking is where the learning is being demonstrated. We're saying, well, actually this time we did this in order to avoid the situation of life-threatening or significant surgeries being cancelled. So I think there's still a lack of understanding. So we know the system is finite, so therefore you need to control the numbers in a way which doesn't allow the system to become overwhelmed. So I look forward to receiving that modelling, but I am concerned about that. I have a quick question for yourself, Paul, and then I have one for Patricia on the vaccines. So Paul, just in relation to the there's other impacts here that have been a result of this outside of the hospital situation. In the Southern Trust, our out-of-hours GP service across the Southern Trust has been contracted back down from 5 sites to 2 sites, severely decreasing the accessibility of our population here in the Southern Trust. Can you tell me what is being done to address that situation? Because surely it just can't be a situation where we start cancelling services. There has to be a plan to provide the services on a fair and an equal basis right across the north.
The staff availability that's affecting other parts of the health service is also affecting general practice, and both general practice in ours and general practice out of ours. And on that basis, Colm, I think we've had to take some difficult decisions to try and keep our services going. GP out of ours has, in all of our areas, been challenged in recent years, just in terms of having enough staff to deliver the service, particularly GP input. And I think now what we're seeing is that the staff availability due to the kind of COVID implications, I think, is challenging us, and we're having to limit that service. I don't know the specifics in relation to the southern area, to be honest with you, Colin, but I know the generality, which is we're under pressure in general practice in ours and out of ours as much as we are under pressure in our hospitals. So on that basis, I think we're going to see these kind of decisions, but hopefully they'll be short-lived. We'll get staff back to work and we'll be able to get the services delivered in the way that we would prefer to deliver them.
Okay, Patricia, in terms of the information that you had given us, and you had said that there are mass media campaigns and that, and I would encourage that, and I would encourage from this platform, I would encourage everyone, all of our young people, to go and get the vaccine, and to do that as quick as possible, particularly when the walk-in centres are still there for convenience. And you have outlined some of the proactive things that you're doing, but in terms of tackling disinformation, what's being done that's circulating on social media?
Yeah, thank you. There are specific initiatives that the Public Health Agency are doing in social media. I think particularly there was some misinformation around the impact on those who were pregnant. So that did stop or made those who were pregnant very hesitant. So they've got, where they're aware of it, they try to put out counter information from very credible resources. I mentioned pregnant women, so it would have come from the Royal College of Obstetrics and Midwives, and and to be able to be very specific and kind of credible and give assurances. So they're chipping away at this, but it's never ending. I mean, it is highly pervasive, as you know. You need to be aware of it in the first place. So where they become aware of it, they watch this very carefully. They counter it as quickly as they can. And one of the things that they've been trying to do, looking at what I was saying earlier about who can influence, is to work through influencers as well. So that where they've got someone perhaps who had previously not been vaccinated and became ill, or through other circumstances changed their mind and came forward for vaccination, they interviewed those individuals. And I thought there was a very powerful interview last night on the news from a pregnant woman who'd chosen to be vaccinated, and I think she'd hesitated for a while and then built up her confidence and went forward. And I think that's exactly what we need to keep doing. It's a relentless campaign, and we just have to be very determined about it.
Okay, thank you, Patricia. So I'm going to go then to members. So the first indication I had then was from Carol Killen, and then going to Deputy Chair Pam Cameron, Jonathan Buckley, Orleah Flynn, Paula Bradshaw, Alan Chambers and Cara Hunter. Those are the indications I have at present. So we'll go across to yourself then, Carol. Thank
you very much for being at the committee this morning, particularly given the fact of the situation that we're in. So for me, the concern I have is that I still don't think it's clear enough, the different modelling between the modelling that's given to the executive, the modelling that's given to the board and then passed down to trusts. But I do think any further clarification would be helpful, and I would encourage you to do that. But for me, the question for me is why has the surge plans, particularly in Belfast Trust, why has the button not been pushed on those? And then surely, the difficulties that we're having, particularly with GPs and out of our services, are going to put pressure on our emergency departments. When are we going to actually tackle the area of workforce planning? Because Ian Young actually said, and he's right, that staff need breaks. But then you seen in Belfast last week, anybody that wasn't on duty was asked to come back. So, it's really around, that's my first question, Chair. The second one really is, given the fact that surgeries are going to be reduced, but hopefully resumed next week, and some of those have been described as red flag cancer surgeries, what message, in terms of Paul as a commissioner, are we going to say to those people, given the fact that everybody accepts that this is a very stressful situation? And my last question really is around the conditions that staff are working in currently. So everyone rightly commends our health and social care staff, and that's right across the board. But we are still seeing images of ambulances being backed up to admit patients. We're seeing health and social care staff to the point of exhaustion and then the step up again. And last week in the Royal, although the situation was rectified for a few days, the windows had to be closed because of the demolition of Bostic House for some days in a heat wave. And the chief executive, in my opinion, made the absolutely right decision to open the windows, but they're now closed again. There's no ventilation. So what are we going to do, not only to look after patients in that situation, but also staff right across the health and social care piece? Thank you.
Go ahead, Paul.
So Colm, and thanks for that, Carol. I mean, it is a sort of a challenging sort of period for us indeed, and you've actually noted renovations, and it's interesting. Summertime is the time when all of our renovations are planned within hospitals, And because we're having a winter in the middle of summer, those renovations have to go ahead. We've got to still get ourselves ready for the services that we need to provide in winter time. But unfortunately, those are now conflicting with the pressures that we actually have within our hospitals. But as you say, I think trusts are doing their best to be pragmatic in relation to that. But nonetheless, the renovations, not just within the Royal, but in all our hospitals as well, are having to be continued. And we are trying our best to ensure that we have across the region supporting any trust that maybe has to sort of close some beds because they have to sort of do some renovations within a ward, which might only take a few weeks. But obviously that has implications because they don't have the headroom that they would have had in previous summers, as you can imagine. But I think the point's well made in relation to renovations, but they are a summertime thing, and it's something that we do want to continue with. The issue of ambulances then being queued up has been a perennial issue for us now in the last number of months in the face of those unscheduled care pressures. The ambulance service now is doing what they call smoothing. So they're basically keeping an eye now on just how many ambulances are at any particular hospital, and they're now stopping sending any more. So they reach a tipping point. Now, unfortunately, I think it was Monday there, we had quite a line of ambulances at the Ulster, but that was because the smoothing there was limited things they could do in relation to the smoothing. But in general, in recent weeks, we haven't seen too much of that. But I think, Carol, obviously it's still an issue for us, and it does reflect just on how many patients the ambulance service is dealing with at any one time. But we're trying as much as possible to prevent that and to divert ambulances to other hospitals that have a bit more sort of capacity to offload ambulances than necessarily going to one that already has a considerable queue, but very challenging. The message to cancer patients is that we will get these services back up and running as soon as possible. Our hope is, and it reflects sort of Ian's comments, that this is a short surge, that within a few weeks we will see ourselves trying to get back to some sort of normal. And we will be able to have all of those patients rescheduled and get ourselves back to doing all the things that we need to do. It is very challenging, and I can only apologise to those patients that we aren't able to provide their surgeries this week. They were ready for them. They were doing all the isolation and so on that patients have to do, getting the testing and so on. So that is really regrettable. But I think the flip side of the coin is we've also got to provide those patients with a safe service. And in order to do those operations, we've got to have the staff capacity to do them. So while it's a minority of the 120 or so operations have been cancelled, nonetheless, every one of those operations is important to someone. And I think we've got to do our best to try and get those rescheduled as soon as we possibly can. Take your point in relation to workforce planning as well. I mean, it is a very challenging period for us. I think we're fully aware that, our workforce is what we rely heavily on to actually deliver the services that need to be delivered. I think the call that went out at the weekend to ask staff to come in was a reflection that this wave came at us about 2 weeks before we expected, Carol, to be frank. So on that basis, I think we did have to take some measures over the weekend, and thankfully some staff sort of followed that call. But I think since then, we are now much more prepared. We've re-established our critical care hub, for example. And that hub then will be managing beds across the region to ensure that we, again, have the kind of care that patients who require ICUs have access to the care that they require. But it has been very challenging, and we have had to think on our feet recently. And I think your first point then in terms of the surge plans, we are enacting our surge plans. That's what's happening right now. And what we're trying to do is keep as much of our elective work going as we possibly can. The vast majority of our elective work will continue this week, and we're hoping to get back to normal, if not next week, certainly the week after. So we will do all that we can to ensure that as few operations are cancelled as we can possibly manage. You'll remember in previous waves, we largely cancelled almost every operation. The vast majority of operations were cancelled. So this time it's the minority, but not losing sight of the fact that every operation is important to an individual and their family.
And Chair, just on the and thank you for that. It's just on the issue of the modelling. I do think we do need further clarification on that, because the modelling, especially the last part that goes to the board and then to the trusts, is actually going to impact on workforce planning right across the board. And I would say, just on behalf of, constituents as well as people who have been in contact with us all, I'm sure, that we just can't keep relying on the goodwill and the commitment of a beleaguered workforce. You're constantly stepping up. And there does need to be, in my opinion, a completely different emphasis on the whole area around recruitment, particularly for staff who have applied to be cleared. None of us are saying take shortcuts, but someone waiting 9 weeks is a bit ridiculous. And then for me, the retention of staff is really important. A lot of them are going to the private sector because they feel burnt out. And we need to stop that flow. And the last thing is we do need to see workforce planning issues, particularly around GPs, because there was problems getting access to GPs anyway. And now with the reduced out of hour services right across trust areas, particularly in the Belfast Trust, and then Columns raised his own constituency, that's going to be a big issue, because if we don't get that sorted out, we're going to see bigger impacts in our emergency departments, and that's the last thing people need. Thank you.
Thank you, Carol. And I'll go then to Deputy Chair Pam Cameron. If I could ask members, if you feel your question hasn't been understood and isn't being answered correctly, if you want to indicate through the chair, just in terms of pressure of time, and I would ask everyone to keep your questions succinct and the responses succinct as well. And if at the end of a sort of period of time there are questions outstanding, maybe we could ask for those to be returned in writing, because I don't want to impact on all the members. So it does work out approximately 8 minutes or so there for each member. So I'll go then to Pam. Go ahead, please.
Thank you, Chair, and good morning, Professor Young, Patricia and Paul. And just to say thank you very much for your time this morning. Obviously, this is an unplanned meeting during recess, and so we do appreciate your attendance here at committee. Obviously, the increasing pressures facing our health service as a result of this fourth wave of COVID-19 are of grave concern. Not least because of the impact that this is having, as we can already see, on elective care throughout trusts, in particular Belfast sitting at 30% capacity is highly concerning. But I also want to put in record, thanks to the dedicated health and social care staff who have been working round the clock, donning PPE in the hottest days ever recorded in Northern Ireland, and often working during their off periods as well, coming back in to ensure that patients receive the best possible care and attention. So we really need to put on record thanks to the staff who have done such an incredible work over the last 18 months, but certainly over the last number of weeks as well. I wanted to look at, first of all, the workforce appeal and where that's at. I mean, as of 2nd of June, only 13.9% of applicants to the workforce appeal have been appointed, and yet only 8% of the applicants have been rejected. So that's suggesting that the vast majority of applications are still active but haven't been progressed to a point where the health service is seeing an advantage or the benefits of having that workforce appeal in place. So I would like to know, why the appeal hasn't been maximised and why we haven't got more out of that, the potential of all those people who have come forward and said, look, I'm willing to come back, I'm willing to do whatever it is they're willing to do. Would like to hear more about that, why we haven't got more out of that workforce appeal, about when, quite frankly, people are obviously willing to come back. And we have heard recently on media around red tape issues and severe delays in getting staff back in. I also would like to know what efforts have been made in approaching and working with the private sector, especially in terms of the elective care downturn. What role can the private sector play in that, and have those approaches been made, or have they been planned in, or is that happening? So I would like to hear a bit more about that for now. Obviously, the vaccine uptake is incredibly important and very successful, and I'm very happy that that the mobile vaccine units are coming out, and certainly coming down from next week. That's very welcome, and I'm trying to push as much as possible to try to get as big a turnout for that, certainly in my constituency for starters. But so it's very welcome that's happening. I think it's a good roll going down. I think Patricia probably needs some more ice cream vans and maybe a marquee with some burgers and a barbecue. So I would do anything to get these young people to come out and encourage them to come out and do a good thing for everybody else. But I would like to know actually, in terms of the vaccine uptake, what the percentage uptake has been now from health and social care staff, because I know that will not be 100%, and I think it's important that that health and social care staff also set a good example to the rest of the population in terms of being willing to take that vaccine if they possibly can. So I will maybe ask Ian if he could maybe give us an update on when the peak in cases is expected, and refresh us as to what the normal lag period is for resulting hospitalisations and admissions to ICU.
Thank you. Yeah, go ahead, Ian, please. We'll start with Ian, maybe.
Yeah, so I'm happy to address the last issue. So at the moment, we reached a peak of 520 cases per 100,000 per 7 days around 4 days ago. And we've declined slightly since then. As I indicated in my introduction, I think there are two explanations for that. One is the recent good weather, in which case cases may rise again. Secondly, it could be reaching a high level of population immunity in the most important subgroup of the population in terms of virus spread, that is the 18 to 30s. And the number of cases in 1830s has declined over the last week. So we'll know better next week, but I think it's possible that the case numbers have peaked or are close to peak at the moment. That does not apply to every part of Northern Ireland. So Belfast clearly peaked last week and has fallen. And Mid-Ulster, for example, is still rising rapidly with no sign of having peaked. So there is some heterogeneity in terms of different local government districts. In general, hospital admissions and occupancy will peak at 8 to 10 days after the cases rise. Now, for individual trusts, the most important factor will be the case numbers in their immediate catchment area. So for Belfast, we might reasonably expect to see some decline in hospital numbers next week, based on the fact that case numbers have been going down now for a few days. Critical care pressures clearly generally lag further 2 to 3 days behind.
Thank you. And then in relation to the workforce appeal and the private sector.
So I'm not close enough to the workforce appeal, unfortunately, Colm, so I'll have to take it offline and come back to you with a written response. As for the private sector, we've been working with the private sector throughout. We continue to hold a contract with Ulster Independent Clinic, for example, and our consultants are able to actually, from trusts, are able to go in there and perform operations. So we're using capacity within the private sector where we can, although the private sector have also brought a lot of their own services back online. So it's increasingly limited the extent to which we can access the private sector. But more generally then, in terms of having sort of elective care, we are working with particular private providers to provide some of that care. On top of that, as you know, we've introduced the Republic of Ireland scheme to support any patients who wish to, to opt to go to services in Dublin, pay for those themselves, and then we reimburse them to the level of the NHS tariff. So we are trying as many and as creative ways to offer other ways for people to access private sector care, to have the NHS care that they require. I think that's something that we want to continue to do more with. We're also working to develop a new contract with private sector providers, and we're hopeful that will also deliver some additional capacity in coming months as well.
Okay, we did lose very small sections of that. I think we were able to follow the sense of it, but there may be just a wee connection issue with you there, Paul.
Okay.
We lost you. Pam, can I just check back with you there in relation to your content there for the workforce appeal figures to be brought back to committee?
The chair, it didn't cut out at our end, so it must be your broadband.
Okay.
No, I'm certainly not content with not having any information around the workforce appeal for now, and I would ask Paul if you could get that to committee urgently, because obviously we can write all day long to the departments, but we know the pressures on departments, and we know responses can be incredibly slow. Even when we are sitting, when we ask questions, that some of the questions are never answered, quite frankly, and are very slow as well. But we do understand the pressure. But on this critical issue, I think that we need to be prepared, and we need to be maximising that workforce appeal. If there are people willing there to help, we need them on board. I don't think we have the luxury of wading through red tape and of maybe being very particular around contractual issues or whatnot. That I think we need to do more in terms of harnessing the help that is already there. But yeah, and maybe Patricia could answer the questions around the vaccine uptake as well. And I wanted actually to add to that, and maybe Patricia would know, or maybe Ian, in around, so the Belfast Trust indicated that 40% of COVID patients are vaccinated. Is there any further breakdown in that? Are these mainly those that have had one dose, for instance, or have they been infected maybe shortly after they've had their vaccines and it hasn't been effective enough? Do we have any more breakdown of that detail as to why there would be 40% still hospitalised with COVID who have actually had a vaccine?
Okay, and brief answers on those, please.
Chair, I wouldn't be able to answer about the Belfast Trust information or indeed the impact of vaccination, and Ian may have a comment on that. But if I can go back to the earlier question, Pam, that you raised about vaccination, and I do very much welcome your comments about the mobile units and the encouragement that anyone and particularly leaders such as yourselves give to it is incredibly important. And I think the issue of incentives is a sensitive one. You do it with a light touch, and you're quite right, it is of the scale that you mentioned. I think that has a good incentive. Other than that, I think sometimes it can have an adverse incentive. What we do know from the vaccine management system is that 150,000 health and social care staff, and that is right across the statutory, community, voluntary sector, those who would have face-to-face contact with individuals. So that means that within trusts, that would be a very high, it's well beyond 80%, and indeed in some of the front line, it's beyond 90%. We don't have exact figures, for example, for care homes, because we took vaccinating teams out to the care homes. So if someone was vaccinated there, it was recorded that they were vaccinated as part of that work stream. But many of them who weren't on duty may have gone into a vaccination centre and just been recorded as a generic health and social care staff and not as care home. So that means it slightly underrepresents what's in there. But we know that that is well beyond 70%, and we know that it is higher than that. And we have a system in place that for new staff, and I'm very minded of your comments about the recruitment, any new staff come in would have an opportunity to be vaccinated. So they haven't missed out just because they weren't employed at the time that the programmes started. But trusts in particular keep a very close eye on this, and they do watch. And this has been the most successful campaign that they've ever run in terms of staff. And we're hoping that will have a really good impact on the flu vaccine this winter, that those who would have taken the COVID vaccine will continue to take the flu vaccine, which hasn't been quite as successful as this. But we hope it has a positive impact.
Thank you. And maybe a brief comment then, Ian, in relation to the rates of non-vaccinated.
Yes, so at the moment, in general, around 2/3 of hospital admissions are of non-vaccinated patients. They tend to be on average of younger age. However, the remaining third have been vaccinated, and the majority of those are double vaccinated. Double vaccination is extremely effective with any of our vaccines against providing protection against severe disease. It reduces your risk of getting COVID a second time by about 70%. So people who are vaccinated can still get COVID, which is why we need to continue with some precautions. But they are 95% protected against the most severe disease and 95% protected against hospital admission or ICU admission or more severe outcomes. Given, though, that around 80% of our adult population is double vaccinated at the moment, then that means that a considerable proportion or a considerable number of individuals will still be at risk of hospital admission even after double vaccination. So it's very effective at an individual level, but when considered at a population level, we will continue to see hospital admissions of the double vaccinated, including double vaccinated individuals with severe disease.
Yeah, thank you, and I'll need to move on there. We do need to be to conclude this meeting at 11. So I'm moving on to Jonathan Buckley. Go ahead, Jonathan, please.
Thank you, Chair, and thank you, panel. Listening to Professor Young at the beginning of this meeting, I was taken aback by the figures that I perceived him to represent in terms of, I think it was, you said, 1/3. And when comparing this wave with other waves, you talked about 1/3 of hospital admissions compared to previous waves, and a percentage from 5 to 6% down to 3 to 4% of admissions to hospitals. And on listening to that, I suppose you can understand my disgust at reading and being informed about the Belfast Trust's decision to cancel some cancer surgeries. I mean, I'm taken aback and aghast by that, because I can't comprehend how we have not learnt our lessons about how damaging this approach is to both patients and indeed the reputation of both trusts and the Department of Health during this pandemic. I have never supported this approach by trust, and as a member of this committee, I want it to be noted that I certainly do not trust it now. I think it's both cruel, wrong and unjust. So with that in mind, and perhaps Paul is maybe best to answer this for me, how are trusts cooperating to maximise elective care capacity and ensure emergency care for all of those who need it?
Sure, Jonathan. I mean, I think that since the opening up, if I can use that terminology, around Easter time, the 5 trusts have met weekly to talk about the current priorities in terms of elective care and surgeries. And the vast majority of those are cancer-related surgeries, as you can imagine. And we've been working through those very much in a prioritised list. So in that way, it's those, we look at the patients across the region who are of highest priority right now to have their surgery provided. And we then look at where the opportunities are to provide those surgeries. As much as possible, we would try to provide the surgeries closer to home. But where we have to ask a patient to go a bit further to another hospital, we will do that, if it means that the patient will get that surgery as soon as possible. So there's been a fairly sophisticated process of working through that. But because the backlog is considerable in terms of working down those priorities, we are still in that kind of sort of priority 2, as we call it, Jonathan, which is really looking at those sort of urgent surgeries, cancer surgeries and so on. We need to move further down that list and look at some of those other surgeries that have been waiting a long time as well. And as you know, the Minister has published the elective care plan that we need to take forward as well in coming years. But it will take us some years to catch up with that, I think, as we've clearly outlined within that plan. So a lot of cooperation, a lot of collaboration, patients being prioritised based on need, and then ensuring that there isn't any kind of a postcode lottery across the region in relation to those priority patients, so that those patients are seen as soon as possible at whatever hospital, but hopefully at a hospital near to them.
Were those cancer patients that had been informed of their cancer surgeries being cancelled, were they offered alternative locations? No,
I don't think that's been possible on this occasion, but I think the intention is to reschedule, and I'm sure that prioritisation group will ensure that does include looking at alternative locations.
Well, I have to put on record, Paul, I think this approach is wholly wrong, and I think it sends completely the wrong message. If we are cancelling cancer operations in summer, whenever we have 1/3 of hospital admissions compared to previous waves, I dread to think what potentially the winter could look like. And I think it goes back to, and I think the Chair mentioned it goes down to now, is there adequate planning in place to ensure that we do not fall into a position where come winter, come autumn pressures, that we're dealing with more of this cancellations, which I think is completely counterproductive and sends completely the wrong message.
And Jonathan, just to re-emphasise, as well as this surge in COVID, it's maybe a lot sort of lower of a surge than previous surges, but as well as this surge in COVID, we have been dealing with unprecedented, unscheduled care pressures in our system for the last 3 or 4 months. We have been trying to do that as much as possible without it having any effect on the elective surgery, and it has not had any effect on the elective surgery. We have reached a tipping point, which also includes the fact that we have some, in Belfast Trust, some 500 plus staff are currently either infected or off due to contact with an infected person across the region. It's a similar picture in all trusts. So it is in many ways a whole range of factors leading to this, not just the upswing in the number of COVID-related admissions.
Okay, and with that in mind, and perhaps you could answer this and probably followed up by Professor Young, you've talked about the staffing pressures that have presented themselves across the system, and I fully recognise that, and I know the pressures that the staff have been under. They haven't got a break from the beginning of all of this. But we're hearing constantly from the hospitality sector, for example, about how there's a ping pandemic. Their staff are being pinged by the app. They're forced into self-isolation, many of them vaccinated, and therefore causing many of their premises to close or operate on a reduced capacity. Are you facing the same ping pandemic within the NHS at the moment in Northern Ireland? And if that is the case, is there another way by which we can manage this process to ensure that we have maximum staff in our hospitals to ensure that we're adequately dealing with the inpatients coming in, both for elective care and indeed in our A&Es and our GPs, which has been mentioned? Is there a different way we can do this to ensure if there is a problem?
So you'll be aware that kind of contact tracing has had to be sort of upscaled in recent weeks, because that's a reflection of the number of cases. Therefore, there's more contact tracing required. And obviously that affects staff. It both affects staff who are coming into contact with patients with COVID in hospitals, but also in their personal life, just in being out and about and so on. So of course, our staff are no different in that way from other staff. But I think we also know that we need to think differently about how we view sort of double vaccinated staff, think about how we use PPE and so on to ensure that we can keep staff in work. But I think that's a conversation that's happening, I suppose, at policy level as well, Jonathan. But certainly we're keen to ensure that, those staff, where we can keep them at work despite contact, that we do that, but obviously do it safely, particularly for the patients that they will care for.
Okay, thank you. So I'll need to move on then to Orlia Flynn. Go ahead, Orlia, please.
Yeah, Gormailgut, Colin. Just to start off, I know, Ian, you had mentioned earlier, and I completely accept and agree that all the officials are under huge pressure, as is the wider health system and all of our health and social care staff. And just similar to Pam, I want to thank all of the panel members for coming forward to the committee here this morning. But I do just want to put it on record. I think it would have been good to have the Minister, the CMO, or indeed the CNO in attendance as well. But thanks very much for coming along. Ian, just to go back to, in your opening remarks, you had mentioned when the modelling is designed, I know you had said that obviously it doesn't take into account some of the broader issues around, societal behaviour and the vaccination. But you did mention that you were assuming an 85% vaccine uptake by July. And I would just like to know, were you considering that whenever you were carrying out the modelling? So were you considering that vaccine uptake of 85%? And more to the point, were you taking into account if the vaccination levels hadn't reached the 85%? Because I'm just thinking then, could the modelling have, I know it's not based on predictions and stuff and you're trying to deal with the numbers you're working with, but was any of that taken into account that those vaccine levels wouldn't have reached 85% and then we would have been in the scenario that we're in at the moment?
So at the beginning of the month, we modelled 85% by the end of the month, which we felt was achievable. And actually we also modelled 90% at the end of the month, which is the position that has been reached in England, Scotland and Wales. And if we could have achieved 90% by the end of the month, we would have reduced the size of this peak by 1/2, and we would have reduced our hospital pressures by 1/2. it would have made an absolutely enormous difference. As it happens, we, during the middle of the month, decided that it looked as if, for multiple reasons, and this is not straightforward, something about Northern Ireland, not lack of effort by Patricia or her colleagues, or in terms of messaging, but for some reason our population is more reluctant to come forward for vaccination than population in other parts of the UK. So we adjusted the modelling, and we have based it currently on 82%. And we're following very closely what we expect based on 82% vaccination at the end of the month. So we do take that into account. The other things that are important are the extent to which people adhere to behaviours. And all members will have their own view of the extent to which that's happening. We've made various assumptions about how we thought people would behave. And I think we've been reasonably close in terms of the case numbers. We've done a little worse than our central scenario in terms of hospital pressures. And the reasons for that aren't clear to us, but in all likelihood do reflect somewhat poor adherence to social distancing, to face coverings, to people maybe mixing in large numbers where they shouldn't be, and just not being sufficiently careful, because all of those things remain important.
Okay, thank you. And I have one more question for Ian, and then one quick question to Paul. So, Ian, just to go back, even if the modelling was revised earlier in the month, was that in reaction to the trusts reaching that breaking point? And in your opinion, could that remodelling have been done any earlier? And I know that you have mentioned that, so at the minute there's the pessimistic, central and optimistic phases, and at the minute we're working on the central modelling. And could you just explain why that is, if in terms of critical care we're in the pessimistic sort of remit, and we're also in pessimistic / central in relation to hospital pressure? So a wee bit of clarity as to why we're still working off the central model, if that's accurate.
So we don't really recommend working off the central model. We present the three models, and the central one is the one that's considered more likely. But in terms of planning, I think it's important to also take account of the pessimistic model, because the pessimistic model is possible and has always been possible. So, we provide the three models. It's not just that we give the central scenario, and the three models people can look at and then decide what's the most appropriate basis for planning. But the bottom line here is the course of the epidemic and the size of it. That's what's causing the problem. It's not anything else. And as Paul has indicated, the difficulties this time have been augmented, I think, by two things. Firstly, for the first time, we're introducing more relaxations at the time of a rapid increase in cases. We've never done that before. We've always introduced restrictions at the time of a rapid increase in cases. And the impact of that is somewhat difficult to predict, because it's a new trajectory. And then secondly, we have the issue of staff needing to take holidays, and the fact that I don't like the term pandemic. I don't think it's appropriate. What we're seeing is a large increase in cases during a time when people have more contacts, and those contacts are being appropriately contacted and advised to self-isolate to reduce the transmission of the virus. But all of that is coming together to make this a particularly difficult period.
And just on that, when the modelling was revised, Ian, was that in reaction to the trusts, some of the trusts reaching that tipping point that Paul was speaking about?
No, it wasn't. The modelling came ahead of trusts facing a tipping point. The modelling was in response to our assessment of the uptake of vaccination and the fact that we weren't going to achieve 85%, we didn't think, by the end of the month.
Okay, Ian, thanks very much. And just quickly then to Paul. So I think the PALM's point on the workforce appeal is really important, and I do think we need to see that breakdown. Considering how many staff are off on leave or are self-isolating, so it would be important to see that those figures if you have them, Paul. And just my question really is: do you foresee any plans to scale down other services? Obviously, on the back of the news that we're hearing around the cancer surgery and the orthopaedic surgeries.
So just to emphasise, so what we've been doing is we've been faced with 1,800 staff off due to COVID-related either infection or contact. We've had to ensure that all of our what we call baseline critical care beds are available to us. So we've now have those in place. But in putting those in place in the face of those sort of staff unavailable to us, added to the annual leave issue, but we've planned for the annual leave in that way, has meant that has had some impact on elective care. But we now have all of those beds open, all of those critical beds open, I think bar 2, so 86 beds available to us. Right now there are 13 empty critical care beds available should patients require critical care. So on that basis, I think we'll see now how the next few days progress. Earlier is our sense. We've done what we can. We actually have also plans in place that by Friday, should we require them, we'll put a further 6 critical care beds in place as well. But as I say, each day we are keeping a very close eye on where things are in relation to what's coming through the front door in terms of COVID-related and indeed non-COVID-related critical care, because all those other services continue and people other than COVID patients will require critical care, as you can imagine. So keeping it under review, but at the moment we have a good bit of headroom in critical care. We have some headroom in respiratory care as well. Our hope is, listening to Ian's points, that perhaps this won't get much worse. And if it doesn't get much worse, and indeed if it starts to get better, we'll switch as much back on as we possibly can. But for now, we've cancelled operations this week. I think we'll reflect over the next day or so on whether we need to have further next week. But let's hope that that's not going to be required, because at least we now are in a better position in terms of managing what's currently coming through our door.
That's great, Paul. Thanks very much.
Thank you. And Paula Bradshaw, go ahead, Paula, please.
Thank you, Chair, and thank you, panel, for this morning. I have a few quick questions. First of all, the policy that came in England around frontline staff, where there's a risk of harm to the service, are allowed to adopt a risk assessment and then take tests every day and come into work. Has that been considered here? And if so, is it going to come forward? The second question is in relation to the vaccination of post-primary pupils. I think Professor Gabriel Scally's come out today. I am very concerned that we're heading into the third academic year where our children, the most relevance, those entering exam years, are going to be off self-isolating and have their education disrupted. We know that British territories overseas like Bermuda that follow JCVI have invited pupils to come forward. So why are we not doing that here? The COVID app, relating to Ian's comment there about Pingdemic, we know how many people have downloaded the app, but are we aware of how many people have deleted it for fear that they may be pinged and be required to self-isolate? And then lastly, and this is for Paul, with reference to the independent sector, and I'm not sure whether you have any sway over this, but I'm aware that the new state-of-the-art ICU unit in Kingsbridge Independent Hospital has been waiting since April for a visit and inspection for registration from RQIA. They have the capacity to support the Belfast Health and Social Care Trust with some of the deferred surgeries and appointments, but they can't do that without this registration from April. That's far too long. We need to be far more agile. And then the last one, in case anybody's any information in terms of the vaccine passport website, apparently is down today, and is there any indication of when it will be back up and running? Thank you.
Colm, I'll maybe take a couple of those and then defer to colleagues thereafter. Daily testing for staff, I think we're looking at all in that space, Paula. And it's the point I'm making about currently staff who are off due to contact, and it might not even be family contact. I think we are looking at what are the things that we can do to actually get those staff back to work. So that's a very significant focus for us. And I know we'll be looking at the testing issues as well. And as for the Kingsbridge issue, I'm happy to raise that with RQIA. I'm sure RQIA are not dragging their heels in any way, Paul, I assure you. But there's a lot of pressures in the system in general at the moment, and RQIA, like all of us, are pretty stretched. But yeah, I mean, if there's an opportunity there to access further care, we've a good relationship with Kingsbridge, work with them on a number of areas. So certainly happy to raise it. Well, I'm not sure how influential I will be, Paula, to be honest with you, but certainly happy to raise it.
Chair, I'm very happy to take up some of the other kind of issues. Can I just say I'm not directly involved in this, but I am aware that I think from last Friday, CMO, CNO and others, there was a letter issued about a risk assessment of staff who'd had the where a situation where a lot of staff had been notified by the app or had contact. So I think that the opportunity for that is already in place. But as I said, I'm not directly involved, but I have heard those interviews and discussions. If I go to the vaccination of post primary children, JCVI, as you know, have really taken a long time to reflect on this, and they've looked at the safety of the vaccine, they look at the risk and the benefit for children, and they've only issued us with interim guidance at this stage. I did put up earlier the 4 categories of the under 18s at this point that they're recommending, and we're starting with that, and we see the urgency as soon as it was that advice was made available to us. This is not over. I mean, they're continuing to consider children. Indeed, they meet on a Thursday, and I know it's on their agenda for today. I know that the chief medical officers of all 4 nations, and indeed I know that in the south of Ireland they have recently issued the comparable organisation to JCVI has recently issued advice to vaccinate the 12 to 15-year-olds. So we're still waiting for further advice on that, but I do understand fully the kind of arguments that the disruption that there's been for those already, and we're ready. We anticipate whatever might come for us, and we'll be ready to vaccinate if that revised advice comes forward. In relation to the vaccine passport, I don't think any of us here present are involved in that part of it, so I'm afraid you probably know as much as we do at this point, but we know it's vexatious to people when such things are interrupted. But we're focusing on getting as many people eligible to get a vaccine passport as possible.
Thank you. Sorry, I think there was just one question missing, and that was how many people have actually deleted the COVID app from their phones so they don't get pinged. Do we know the figures?
So that's not information which we would have. It may be available from the department via the Chief Digital Information Officer, and I would have thought a question could go and the information could be provided. I know colleagues are working very actively in relation to COVID certification and the issues that have arisen with the app, which the department has issued a statement on, and my understanding was hope to have that working again as soon as possible, and have put interim arrangements in place to try to ensure that individuals who need certificates for imminent travel will be able to get them, although I fully understand the challenges and problems that people have been experiencing around that.
Sorry, technology problems this morning, your panel. Apologies, but thank you for your answers. Thank you, Chair.
Thank you, Paula. And Alan Chambers. Alan, go ahead, please.
Chairman?
Yes, I hear you there, Alan. Thank you.
The chairman earlier, and I paraphrased your words. You comment the officials that they continue to do the same thing. Why do they expect to get a different outcome? And I just comment that after decades of underfunding of the NHS, why would we as politicians expect different outcomes in this crisis? We expect the health service to deliver despite the historic decisions that have in effect tied one hand of our NHS behind our back. And, we as politicians can sit here today and we can express outrage at the present situation, but I think we have to accept a degree of responsibility. In relation to vaccinating, I'll ask Patricia. Patricia, the under 18s are not listed as being available to get the vaccine. I don't know whether that's because of safety concerns or whatever, but that particular cohort, they're well capable of contributing quite substantially, I would have thought, to the transmission of the virus. If there are safety issues, and that's the reason why we're not giving it to the under 18s, how can we justify then giving it to those under 18 who are vulnerable? Another question in relation to the booster jabs, I'm just wondering, is that just been explored, or is that a given that will happen? Will we receive the same vaccine as we did in our first 2 doses? Who will deliver those boosters? Given the pressures that GPs are under at the moment, will we just be adding to that pressure if they are going to be asked to deliver the booster jab? And will it be done maybe in conjunction with the seasonal flu jab? And just a final question maybe to Paul. Paul, is the NHS facing the most challenging winter in living memory?
Chairman, if I come in, if you don't mind.
Yes,
Alan, if I deal, first of all, JCVI take a lot of evidence around those children who've already been vaccinated. So when they make a recommendation, there has to be more benefit than risk to them. So at this moment in time, those groups that they've recommended, there's more benefit than risk to them getting the vaccine, but they're still considering it. Less than a year ago, these vaccines were unknown, and so there's a lot of experience now. So I do think they will keep reviewing this and considering it. I think for those between 18 and 29 who haven't come forward, some of the issues have been that they might have had personal safety concerns, but for most of them, I think it's really that they don't think they're going to be affected by the virus. Therefore, they don't personally see a benefit, and I think those are the messages that we're trying to communicate, because it may not just be about them; it'll be about their friends, family, and the community. The booster campaign, very happy to just say very briefly, we have received interim advice. We have done some detailed planning. It will start in September. There definitely will be a booster. It will not be for everyone it won't be necessary for everyone who's been vaccinated first time. And we will have a partnership approach again, Trust's community pharmacy and general practice. We supported general practice this time with additional vaccinators. We'll continue to do that in the booster programme. The advice we've received to date is that it should be co-administered with the flu vaccine, if possible. And given that that's the case, it can make this really quite efficient. So we're trying to be very proportionate to try to take opportunities. We've got a lot of experience at doing this in a very efficient way now. So we're going to bring that experience to the booster programme.
And in terms, Alan, then of your question in relation to winter, as I said in the introduction, we're already above what we would see as a normal winter. Here we are in the middle of summer. So, we do dread to think what the winter will look like, Alan. My hope is, my optimism is, because, we've got to keep staff morale up in relation to this, that the things that we're doing today in terms of new discharge pathways, in terms of having the beds that we need within our hospitals and so on, will take some of that pressure off. But I think our hope is that we'll begin to see a turn in our unscheduled care pressures. But I think we also recognise that some of our unscheduled care pressures relate to the care delayed. People who have had to wait longer for the likes of operations and outpatient appointments and so on, who are beginning to have worsening of their conditions. So all I can say, Alan, is I hope not that we're not about to go into an even worse period in the winter. And I think all we can do is plan as much as we possibly can and hope that our staff have the resilience to deliver the services that we'll need in the coming months.
Okay, well, listen, thank you for all you're doing. And I think that we have to all realise that we are all still in this together. Thank you.
Yeah, thank you, Alan. And Cara Hunter. Cara, go right, Lydia Hall.
Thank you, Chair. Good morning, panel, and thank you all for being here this morning. And just to note my thanks towards yourselves for your hard work throughout this extremely difficult time. I have a question this morning specifically around visitation. We've seen throughout the pandemic how visitation to hospitals with patients has been impacted, specifically with maternity expectant mothers, and then also with patients experiencing or receiving palliative care. I'm just wondering, as we talk about the rise of cases, hospitalizations, can I ask for clarification and assurance? I suppose that as the pandemic, if it happens to get worse, that expectant mothers will not be expected to give birth without their partners there.
I suspect that's a good question for me, Colin, and unfortunately, Cara, I'm not the right person to ask that question of, so all I can do is apologise in relation to that. I mean, the difficulty we have, obviously, with the number of cases is obviously the infection rate then of patients who are in hospital. We are particularly concerned that people contract COVID in our hospitals, never mind those patients who are having to come to hospital with COVID. So I think we're doing all that we can to limit the risk of people contracting COVID in the hospital, and that's part of the reason why the visitation is happening in the way that it's happening. I know that colleagues in maternity services are doing all that they can to offer women, sort of pregnant mothers, the support that they need. But I'll need to come back to you, unfortunately, on the detail of that, Cara. I'm not cited enough on it, so apologies for that.
No worries.
I can just probably add something, which is to say that at the moment it's likely that at least one person 100 in the population has COVID, and therefore anybody entering the hospital, 1 in 100 visitors are likely to have COVID, given that many patients are relatively asymptomatic. On the plus side, the number of patients who are becoming infected with the virus in hospitals is much reduced compared with previous waves of the epidemic, which reflects both improved understanding of the virus and measures in hospitals, and also the vaccination programme, both for staff and for patients and visitors. So certainly there's not quite the same strong case as existed earlier in the epidemic for the need to impose restrictions in general terms.
Thank you, Ian. Thank you. Just moving on then to my next question. It also surrounds the delay and the cancellation of cancer surgeries. I know it's been touched on about what lessons have we learned previously to ensure that this doesn't happen again. But I'm just wondering what other kind of avenues are being explored. Perhaps facilitating surgeries in other trusts that are under less pressure. Is that being explored? Also looking at north, south, east, west, what other opportunities are being explored there? Because I do share very strongly Jonathan's sentiment about these are life-saving surgeries, and we have to kind of explore every mechanism that we can to ensure that people living with cancer get their surgeries and have their lives saved.
And I think, Cara, that we are, as I mentioned before, we have we're looking as the 5 trusts work together to see where the patients with greatest priority, largely cancer patients, where we basically can deliver their surgery as soon as possible. So it's not necessarily at your nearest hospital, although as I said before, we try as much as possible to not have people travelling too far unnecessarily. So we're doing that. We have green pathways in all of our hospitals. Belfast City Hospital has a number of green pathways. So ways of just ensuring that whatever happens with the pandemic, as much as possible, we protect a part of each of our hospitals so they can continue to deliver the surgery that they need to deliver. And you can imagine that it also requires patients to have isolation and so on, and testing in advance of their operations, which I appreciate is an inconvenience, but that's about protecting those green pathways for other patients as well. And largely our patients, I think, are very supportive of that. Because I think they recognise it's not just for themselves, but it's also for the others that we're thinking about as well. It is very challenging to maintain those green pathways in the current surge that we're in, with the unscheduled care pressures that we have as well, Cara. But I think we're doing all that we can to do that, and we are exploring other avenues. As I said before, we're looking at the Republic of Ireland. We're working with sort of local independent hospitals. We're looking at all our independent providers to deliver some of that surgery, and we'll continue to do that. And we're hoping to draw additional independent providers from outside Northern Ireland to provide contracts for us largely they will come to Northern Ireland and deliver those surgeries. And that's something we hope for in the next few months. Contracting, unfortunately, can be a slow process, but we found ways of being fleet of foot in the past year as well. But it's a very challenging position. And on top of that, we need more resources, as members will be well aware. But I think we want to also ensure that we have maximised the resources that we currently have. So our focus is on the money that we have today and the resources that we have today. But we recognise that in order to do the things that we need to do more generally, we need to take forward our elective care plan as well.
Thank you, Paul. And then just lastly, Patricia, just a question for yourself. Alan had touched on there about booster jabs and what potentially that rollout may look like. Can I just ask, when it comes to booster jabs, what kind of demographics do we anticipate will be held as priority? And also just on the walk-in clinics, which I think have been a great initiative, will that be carried out for booster jabs also? Thank you.
Thank you, Cara. We haven't completely planned out every part of that, but the interim advice that we received very recently is that it's somewhat similar to the winter flu vaccination programs, that other than it's for anyone aged 50 and above, anyone who's clinically extremely vulnerable who is vaccinated first time around, anyone who's clinically vulnerable, and frontline staff, not the whole of the staff group this time, but only frontline staff. So that means, and within that, of course, the number one priority group is care home staff. So we do that in that order. We are waiting to have confirmation about what vaccine will be used. I think Alan asked a question earlier, and I've just realised I didn't completely answer it, which was that we are yet to receive advice about the vaccine. We expect that it will be something like Pfizer, and therefore we have to manage. The vaccine will challenge us, as you know. I think it's not likely to be mobile teams in the wintertime. That is a more challenging affair, but we'll work out how we can do that. It's a single dose, and it will only be for those who already had been doubly vaccinated, and we're waiting for advice on what the dose interval needs to be, if there is one. It might be 6 months from the second vaccination, but we're waiting for that advice. So we've done, as we did the first time round, a lot of planning on, if it's this, we'll model it that way. If it's this, we'll do, so I expect we'll have a plan within the next 2 weeks, and we hope we'll have the revised and final advice by that time, so it allows us to start putting in place, because we're going to start to vaccinate the boosters in September.
Okay, that's great, Patricia. Thank you all. Thank you, panel.
Okay, thank you very much, Cara, and thank you members for attending, and also want to thank the panel for making themselves available today. We certainly would have liked to have some of the issues just weren't able to be addressed, but we appreciate the fact that you are here and have done your best. I think I do want to touch on that in terms of that workforce appeal that Pam and Arlea mentioned, in relation to, particularly now heading into the winter and what we know could be a very difficult winter, that we use the time to mobilise every single asset. And Paul mentioned resources there. We need more resources. I'm conscious, as is Pam, that there's over 3,000 people responded to the workforce appeal, over 1,000 or around 1,000 to the vaccination. Only small numbers of those have really been put on the ground. And I think we need to absolutely maximise that, to take pressure off other staff, to take pressure off GPs, etc. Also, the issue of nurses, we know it's been reported in the past week, 72 nurses out there willing and able and keen to get involved in this endeavour, but are awaiting checks. And like everyone else, I'm not asking for checks to be short-circuited or any risks to be taken with patient safety, but I'm asking for those to be prioritised, given they are such key workers, and given they're so badly needed, and given that we're asking over and hard-pressed staff to sacrifice their leave and come in and help out. So I think we need to be creative, imaginative and energetic around that issue, and I would appeal for that to be the case. I would also like to, and it hasn't been touched on today, but I'm aware that the healthcare staff payments are coming out at the present time. Some staff have received them and some haven't. There are issues, I know, with private, independent and primary care staff, but I would ask the department takes very quick consideration of how they can address questions and answers that are arising now within the staff group, because it's causing confusion, it's causing frustration. It may create a situation where some staff feel that they have been not treated with the same respect as other staff. So I would ask, given we're in the summer period and given there's so much confusion, that there is a resource made available from the department to deal with queries in relation to the rollout of the payments. please. And the final thing then, I just want to ask on, there has been a significant breach in terms of the COVID data, in terms of the COVID cert app. Can I ask what the extent of that breach has been? Have the people impacted been contacted and made aware? And are there procedures in place to communicate information north-south in relation to the COVID certification process?
So perhaps I can comment on that. So I know that colleagues in the digital service have been actively and fully investigating the breach and the reasons for that. I know they've been in contact with the Information Commissioner's Office, and that all appropriate measures will be taken in relation to fixing the breach and to notifying where appropriate those who might have been impacted by it. I'm not in a position to provide any further full details of that because it's not something I deal with, but clearly it's something which is being treated very seriously and handled as rapidly as possible to correct it.
Okay, thank you. And just to reiterate, thank you all for attending today, and to wish you all the very, very best in the time ahead, you and all of your staff groups. We fully appreciate everything that you and the entire team, the entire staff cohort are doing and are being asked to do. And by all means, I reiterate every word of support that has been said here at this committee today. So thank you for that, and please, good luck in the time ahead. So thank you. Okay, members. So there has been a number of additional pieces of information there that have been indicated that will be forwarded to us. Are there any other comments or members? Any other comments or actions briefly? Or we await those for the piece of information coming back. So I would also like to thank members for attending and for making yourselves available.
Sorry,
go ahead, Pam. Yeah, go ahead.
Sorry, Paula. Sorry, Chair, something's wrong with my technology today. I was just going to say I thought this morning was extremely helpful, and I'm a little bit concerned that it might be 6 weeks again until we as a health committee meet. There were so many issues there this morning. I think probably all could have taken the 2 hours ourselves with the amount of queries we're getting from constituents, etc. So I'm just wondering, is there any consideration for maybe in 3 weeks' time for us to have another recall of the health committee? I think it would be very useful to be considered. Thank you.
Okay, and our next planned meeting is on this Thursday, the 2nd of September, which is 2 weeks earlier than the restart. So I'll take a view then from our members in relation to the session we just had, or anything else. Paul, just to let you know, we can let you go then. Okay. We're discussing with members, so just let you back to your very busy role. So thank you. Any other thoughts, members, in relation to today's session or Paula's suggestion?
Chair.
Yes, Pam.
Yeah, just say I don't disagree with Paula there, and I think especially on the back of the workforce appeal issue, I think we need to be really concentrating more on that and asking more questions on it, because I just think it's completely bizarre that it's such a tremendous response to that appeal that we don't appear to have harnessed all that help that's available, and given where we are and how difficult it's been for health and social care in the summer months, what we're heading into in the winter, for sure it will be worse given the delays and the backlog on the waiting list. So I think we should be continuing to ask questions and to scrutinise what's happened with that over time. Okay. So it may well be useful if there was even a brief meeting just to update in between times. I'm happy to do that if that's helpful anyway.
Okay, well, would members be content then to leave that myself and the clerk will look at how that might be arranged or how we can facilitate that in a way that maximises benefit and also places the least pressure on staff, assembly staff who are currently trying to get their leave taken during the period. So I'll work with the clerk on that. So okay, members. Then the only other thing then is date, time, place then of next meeting. will be confirmed back by email after we have seen what is the potential and how we could set that up. So thank you, members, for your attendance today, and I wish you all the very best. And I would also say to each and every one of you that I think it's going to be important to try to get a break at some point over the summer, because we are clearly going to be facing a very, very busy winter, autumn and winter, and we're going to be hitting the ground running extremely hard in September. So we will be meeting again before that. So I'll come back to you in relation to that when we see how that can be coordinated. Thank you, members, and take care.
Bye, everybody.